Welcome everyone to the Sewell Report and Health. The event is part 2 of the Sewell Report Leicester Response, which is a series of panel events looking at the Commission on Race and Ethnic Disparities, the Sewell Report, and its implications for race relations in Leicester and the UK. Speaking at today's event are Professor J.S. Bamrah, who is a consultant psychiatrist at Greater Manchester Mental Health NHS Trust. He's also an honorary reader at the University of Manchester and chair of the British Association of Physicians of Indian origin. And we've got Dr. Linda Bello, who is a GP and chair of Cameroon Doctors UK, which is an association of medical doctors and dentists of Cameroonian origin living and working in the UK. We've also got Mr. Jagtar Singh, who is chair of Coventry and Warwickshire NHS Trust and works in Colchester and London. And we've got our very own Councillor Keitarik, who chairs the Health and Wellbeing Scrutiny Commission at Leicester City Council. The series of events that we are planning, which we have planned, the series of which this is part, draw on the structure of the Sewell Report and facilitate a series of conversations looking at and responding to what the report says about education and training, employment, fairness at work and enterprise, crime and policing, and health. The series encourages the city to make its own recommendations around the issue. And the reason why we are doing this today, the reason why Leicester needs to engage with these issues is because of the position that it has. Leicester is currently the first plural city in Europe where there's no single group that forms more than 51% of the population. And also, according to the 2011 census, 55% of children in Leicester aged 5 to 19 are from Black, Asian, and multiple heritage backgrounds. Also, researchers found that in 2015, researchers from the London School of Economics found that Nabra Road in Leicester is the most diverse city in England. And the city celebrates its diversity and its pluralism. But at the same time that we have this, there are also some issues that we have that are deeply problematic, issues around racialized inequalities. For example, unemployment in Leicester among Black people is so high that it is of national significance. And there are also issues around health inequalities that affect people from Black, Asian, and ethnic minority backgrounds. So why it is important for us to have these conversations is we need to look at what reports like the Sewell Report say and respond to them based on the evidence and the experience that we have. The reason for that is because we will not change things if we don't look at what is happening. We need to look at what is happening and we need to respond and we need to put measures in place to change what is not working and also build on those things that are good. So we will start today. Again, I will say that this meeting is being recorded. We will share the video through YouTube and also through Facebook and Twitter. If you are on social media, please follow Civic Leicester. Also follow us on Facebook and YouTube. Without more, I pass on to Professor Bamrah. Over to you, Professor.
Thank you. Now I need to thank you very much, Ambrose, and I'm very grateful to you, and of course the opportunity to talk about this report, and also greetings to my fellow colleagues, Dr. Bello, Jagtar Singh, and Mr. Keitarik. The Sewell Report was released on the 31st of March 2021, as you're aware, and it has significant implications for ethnic disparity and discrimination. I thought I'd just take you through some slides to put a little bit of a context, particularly in view of what's happened around COVID, and hopefully this will go smoothly. And then I'm very happy to then tell you what I think about the Sewell Report. Now let me see. So this should work, hopefully. I hope you can see this. Can you? Yes. Okay, good. So, well, of course, racism in the NHS is a very topical issue, but racism in society, which racism in NHS reflects, is also very topical. Now, we know that there have been ethnic disparities through our society for some time. There are ethnic disparities that have influenced treatment outcomes in patients with tuberculosis, cancer, schizophrenia. During the H1N1 pandemic in 2009-2010, it was evident that non-white ethnic people were already suffering higher mortality rates. And that wisdom was not applied to this pandemic, as you're aware. And this has been an issue also in the States. And when we look at health disparities amongst over 400 individuals permanently registered with general practices in London, BMA groups had the highest prevalence of type 2 diabetes compared to white individuals. So there was something in the fabric of society, I'm afraid. BME groups develop diabetes at a younger age compared to white individuals. The prevalence of hypertension is considerably higher amongst Black, African, and Caribbean groups than in white populations. And similarly, I could go on about many other things. And this slide puts everything into context. The high bar right at the top is of people of a Bangladeshi origin. And the lowest bar, which is a slight brown color, are people of white origin. And you will see that almost every single ethnic group fares pretty badly in terms of health, self-reported healthcare. After the age of 60, all of the ethnic groups come together, but prior to that, the African and Caribbean, Pakistani and Bangladeshi people seem to do rather badly in terms of their health. And during COVID, we saw that when you look at Asian Black, which is the blue bar compared to the orange bar, where the blue bar is up, it means that the disparity is worse, which was the case particularly with Black people, but also with other Asian and other ethnic groups. So there are a number of explanations for this, which is social, economic, and health inequalities that exist in society, genetic predisposition, and perhaps a little bit of genetic influence and our higher burden of comorbidities that BME people carry. And of course, vitamin D deficiency might have played a part too, which is something that fairer skins have less of. So the darker the skin, the more the vitamin D disparity, disparity, shall we say. And so why do BME people, why are they particularly susceptible to this? Well, it's hard for them to practice social distancing. Working from home has been difficult because many are in low-skilled jobs, difficulty from isolating from older family members because they live in joint households, and therefore they found difficulty to isolate themselves from the sick. And so The Guardian carried this headline, BME groups hit harder by COVID-19. This came out on the 7th of April. First paper to hit the headlines was The Guardian. And of course, the early warning signals were there. BAPIO wrote to the government about this, and there was an NHS Confederation alert as well. So what I'm trying to say, Ambrose, is that these sorts of disparities, in the interest of time, I'm very happy for you to have my slides, but these disparities have existed for a good number of generations. And there have been headlines to say all of this. Is the virus racist? Certainly it's not. Or is the NHS institutionally racist? Something that the Sewell Report failed to grapple. There's something in the fabric of society that has been exposed by COVID-19, such as the economic impact of shutdown, which has been disproportionately more in minority groups, many of whom work in low income self-employment jobs with uncertain incomes, and other people more likely to be financially affected, apart from Pakistani and Bangladeshi people, are also well, in the age range of 30 to 44, which is the key age in terms of economy. Bangladeshis were particularly affected. And so, again, as this slide demonstrates, there has been the physical health disparities, which I talked about earlier in my slide, have been very evident for some time and were actually laid out by Sir Michael Marmot in his report too. Access to primary care also has been poor, and mental health, which is obviously dear to me. There are diagnostic disparities because people of an ethnic origin are more likely to be diagnosed with schizophrenia and bipolar disorder than white people. And of course, as we now know, for some time, Black people are greatly disadvantaged in terms of the police and criminal system. The impact of racism is quite profound. COVID-19 has demonstrated that clearly institutional racism is deeply embedded in British society, and hence the NHS at a lesser level, it leads to a failure of an individual or a community to thrive, and at extreme end, obviously, can lead to violence and death. Racism leads to unequal access to healthcare, social services, education, employment, and housing. It has a major impact, and this is something that we need to think about, impact of racism. Black lives matter, all lives matter, all houses are burning, but the Black house is on fire. That is why we need to act. The Sewell Report, which has 24 recommendations, some of them very good, fails to tackle that idea, the missed ideology that there is no institutional structural racism. And that is what I wanted to say. Thank you very much, Ambrose. I will pass on back to you.
Thank you very much, Professor Bamrah. And then we go on to Dr. Linda Bello.
Hi, good morning. Thank you very much for asking me to speak today. My name is Dr. Linda Bello. I'm a GP. I work in London and an inner city practice, and also in Colchester. I qualified from the University College Medical School over 15 years ago. I've worked in the NHS for over 15 years ago. Thank you for giving me the opportunity to air some of my views and thoughts. And a lot of it will just follow on from what JS has said. When the report came out on the 31st of March this year, I mean, I was quite dismayed, if I could be very honest. As a Black and ethnic minority doctor, I've seen firsthand that there is racism, and I've seen what kind of impact it's had on my patients and from my colleagues from ethnic minority backgrounds. The report, the CRED report, or the Sewell Report, did rightly point out that the minorities and immigrants, including sort of white minority groups, were more likely to experience mental health difficulties as they migrate to countries worldwide where the majority of that population is white. But unfortunately, the report did not actually try to find out why these groups, and I always want to say we, but these groups are experiencing these challenges, and really fail to acknowledge the well-established links between racism, discrimination, and health, as JS has pointed out in his slides. Actually, there was a government report last year beyond the data, which we're trying to understand the impact of COVID-19 on BAME groups. This report was mentioned in the Sewell Report, and this particular report noted that the racial discrimination that is faced by ethnic minorities does affect their life chances, and the stresses of being discriminated on has an adverse impact on our mental and physical health. It has also been shown that this racism starts in medical schools, unfortunately, and seems to seep through all the layers of the training. The BMJ this year revealed that medical schools were actually failing to monitor the racial harassment and abuse of ethnic minority students. The RES, which is the Workforce Race Equality Standards, reported that 82.7% of NHS TROTs were reporting a higher percentage of ethnic minority staff had reported that they were bullied, harassed, or had received abuse compared to their white staff. So 82% of NHS TROTs compared to the white staff over 12 months. So those are not figures that we can ignore. Ethnic minority doctors face a disadvantage throughout their careers because they're more likely to face more disciplinary action compared to their white colleagues, more likely to face GMC sanctions, more likely to get complaints. We do not need to look any further than the recent case of Mr. Omar Karim. In the past, Mr. David Selu, Dr. Baba Gawa, we all know these names. Last year, Public Health England Public Health report showed that Chinese, Indian, Pakistani, and Blacks had a 10 to 50% higher risk of death from COVID-19. So 90% of doctors and 70% of nurses who died from COVID-19 were from ethnic minority backgrounds. So unfortunately, most of my colleagues, I personally will know someone who died from COVID, and this would have undoubtedly had an impact on our mental health. So how can there be no evidence of systemic inequality when we have data, for instance, showing that Black women are 5 times more likely to die when they're having children during childbirth, that Black minorities are undertreated for pain, Black men are 4 times more likely to be sectioned for a mental health condition. At my surgeries, I've been able to see firsthand what the tag of being a difficult or argumentative patient can just stick on a patient, ethnic minority patients generally, and lead to a poor patient experience for them. This usually leads to the patients not engaging with us, their doctor, and of course, a poorer health outcomes. We also know that they present with their symptoms very late. A report last year by the Race Equality Foundation suggested that doctors were uncertain when it comes to diagnosing emotional problems and depressions in ethnic minority patients. As Jay mentioned before, the ethnic minority groups usually have a higher risk of diabetes and hypertension. These conditions are associated with a poor outcome from COVID as well. And they do require regular monitoring to ensure good control of the diseases. But the lack of engagement will lead to poor control of these conditions and therefore the poor health outcomes. We're also, BAME are also, the ethnic minority groups are also experiencing a disproportionate burden of COVID deaths, but unfortunately are falling behind on the vaccinations, COVID vaccinations. So the narrative is that is due to cultures and beliefs, but there is a lot of vaccine misinformation, which I really personally feel should be addressed and targeted in a non-judgmental approach, perhaps through the media. What my association has done, CamDoc UK, we've been holding a series of webinars during the pandemic to try and address this vaccine hesitancy, to try and to discuss COVID and to generally educate our community. During these webinars, we've actually done surveys before and after that have shown that their views have changed when they've heard us speak, people that look like them, people that they trust. And we continue to provide these kind of webinars in our own time and make ourselves available through our website and email for any further questions. Several other associations are doing this, BAPIO, Better Health for Africa, for which I'm also a member of. I've been involved in vaccinating these patients at my surgery and also at other centers. And what has really struck me is the complete trust that you find in white people, so non-ethnic minority people, compared to the ethnic minority groups who are usually the ones that have questions and are worried about things. And I'm not surprised, because if you hear the facts like the ones I've just told you about, Black women dying 5 times more likely to die in pregnancy during childbirth, you might be hesitant to seek help. You may actually feel that the very people that are seeking help from you are going to harm you. Some of my patients and friends and family have read about the Tuskegee Study, which took place in the 1930s, which was a US study of syphilis that left Black men to suffer from the disease. And the study had offered free meals and checkups, but they never explained that the participants would be human subjects in a study which was designed to withhold medical treatment. So of course, this will undoubtedly leave, Blacks, ethnic minorities, a bit hesitant about taking the vaccine unless they were giving the facts patiently and persistently, which is what we're trying to do. So during one of my webinars, actually, I actually had to inform the community that, there's no difference when I'm vaccinating and what vaccine I'm giving to white patients or to them. We have to reassure them that me and all my colleagues have taken the vaccine. We've shared photos of us having the vaccine. We've highlighted that we have no pecuniary interest. No one's paying us to promote this or organize these webinars during our free time. A very common comment from some of my patients is that they don't feel listened to. They feel they're not being helped. I really strongly feel that this particular group needs more patience and more time, and more rapport needs to be built alongside the trust that we're trying to get. Thank you.
Thank you very much, Dr. Bello. So what we will do is we'll have the speakers first, and then afterwards we'll have conversation, and then proceed to a Q&A. We go to Mr. Singh next.
Thank you very much for inviting me to speak. I'm here today. You introduced me as Chair of Coventry and Warwick Partnership Trust. I think I want to be free to say whatever I wish, and therefore I'm not going to use my title of chairman of a particular organisation. I'm here as Jagtar Singh. I also run a little consultancy called JS Associates, but that's why the logo is the back to prove that I'm here as Jagtar Singh, and I'm here to share my experiences. But before I share my experiences, Jay's Bamrah, spot on. I could just say I've got nothing to add. I agree absolutely with Jay's Bamrah. I could also say I got nothing to say. I agree with Linda. So on the key points of Jay's Bamrah, racism exists in the NHS. That agrees with Linda. She's given you some great examples. On the deaths of BAME individuals during COVID, what's that about? If you're using about institutional discrimination or structural discrimination, nobody's proved any evidence that it was nothing, it was something else. On the Black Lives Matter, we had last year 2 things running at the same time that told us intuitively that the CRED report was discredited. Black Lives Matter and COVID-19 exposed with a sharp focus that inequality in the UK exists. Where people were running around saying white privilege, I got no white privilege, not even understanding what that meant. Black Lives Matter, white lives matter too, not understanding at all what that meant. JS gave a great example of how to explain that. Leaders in the NHS were saying, I don't understand Black Lives Matter. I'll tell you what, if I told them this black spot you got on your forehead is going to kill you, they'd Google black spot on my forehead, how would it kill me? They'll find out about it. But they were idly, lazily saying, I don't understand. People of color like you, I, Linda and others were going around trying to explain to them what it means. They could have Googled it and found it in 5 minutes. Laziness and no intention to learn really, but to say, I don't understand. Linda's questions around vaccine hesitancy. I told them in April of last year, this was an issue. Why did I know? Because I've got a board that's diverse. I've got a black board with 2 black members. Already in the black community were WhatsApp messages, video messages telling them they would be experimented on for the vaccine trials. There was already a creation of a negativity about the vaccine and COVID. COVID denial was also there. I informed through the NHS Assembly, probably one of the most powerful groups, NHS England, NHSI, this was an issue they need to address. Did they do it? No, they didn't. They did not want to fan the flames of the negativity, and yet they were allowing the negativity to outgrow their own multi-million-pound campaigns. So that's where I absolutely agree with my colleagues. So what else do I have to add? Well, I'd like to place this conversation in a conversation to say the paradigm of the discussion is broken. How we discuss racism is broken. So let's fix it. How should we fix it? Well, I think we can fix it by understanding, one, the regulation around racism, institutional racism, structural racism is absolutely broken. The law is there. Those of you who are as old as I am will know that the death of Stephen Lawrence gave us the tool to get rid of institutional discrimination and structural discrimination. It's called equality impact assessments. Had they been applied by the public sector, private sector, we would not be having this discussion. So we've got a law, we had a law about seatbelts. It didn't work. People were still dying on the roads. Law wasn't being enforced. And then we had a twin campaign of enforcement and education. And what happens? Actually, on a human side, you know what happened? We have less organ donations now than we had pre-enforcement because there's less road traffic accidents and less people dying, and we can't find the organs that we used to have freely before when people were allowed to do whatever they wished. So it can be done when the will is there. The will is not there from government. The will is not there from the majority community because it will benefit Black communities. So what else can we do? We can have what J.S. Bamrah said, evidence-based actions to lead to clear outcomes. I'm sorry to all of you youngsters. It's my fault we are where we are. We have educated the white community how to hold us back. We have educated them in the language of equality and diversity. They can talk us to death about commitment and leadership with not doing anything. That reminds me of a conversation with a colleague of mine, Waqar Azim. And that was way back 20 years ago. And he said this: we have educated our leaders. In the past, we used to bang our head against the wall and our forehead used to bleed. I go now into big boardrooms, I go into government offices, I bang my head against the wall and a wonderful cushion appears and cushions my head. And I think they get it. I walk away and the cushion has come back to what it was before I entered the room. That is where we are today on this matter. So we need action, we need evidence, we need measure of outcomes. We need to understand how unconscious bias does work. We don't need the lazy interpretation that unconscious bias doesn't work, therefore get rid of it, or unconscious bias is the answer. It's more complex than that. Unconscious bias exists, and a simple solution offered by Sheffield University professor was, if you just tell your staff there's unconscious bias and how their decisions are impacting, the thing will change. In my trust, we did that, and we reduced our discipline rates for Black staff just by telling them this was the action they were taking, this was the impact. We didn't have to go on a load of unconscious bias training. Stop writing more reports. I did a report from NHS Assembly around health inequalities, and you know what? On every website of every arm's length body and every government, there's loads of evidence. Marmot report, King's Fund report, definition of health inequalities, it's all there. Recommendations, they're all there. We don't need to tell them what to do. They know what to do. They're not doing it. So how do we make them do it? Well, we say we're going to stop weighing the pig. It doesn't make it any heavier. We're going to start to make the pig fit. We want this outcome. We want these actions to be implemented. We need a repository of good practice. And you know what good that will do? Good organizations will put good practice forward, and it'll sit there. We then need the regulators to say, Mr. Singh, your neighboring trust has reduced racism against your staff by 100% by using this practice. Why are you not using it? So good practice isn't just something that you post and get awards for. Good practice is what everybody is expected to come up to. Accountability, responsibility would be other things I would say, but time is probably running out. So summary, I disagree that institutional discrimination doesn't occur in this country. There's plenty of evidence offered. I disagree that structural discrimination doesn't exist in this country. Plenty of evidence that it does. I disagree, we need to change the term BAME. My colleagues will say to me, I don't want to be called BAME, I'm Indian. I said, call yourself Indian then. I never told you you were BAME. Nobody has ever asked me to tick a box to say I'm BAME. But they do ask me whether I'm Indian, Sikh. However, if we don't have the understanding, using Linda's example, white women, BAME women, disproportionate deaths in maternity, how will we ever know what the difference is? This country has the worst outcomes of all the developed countries for women during pregnancy. Ockenden report. Did the Ockenden report divide them between black and white? No. Did they then divide them between black and Asian? No, they didn't. Did they discover that Bangladeshi women have the worst outcomes of all? No, they didn't, because they didn't do the intersectionality point. And yet, going back to my case study point, in Tower Hamlets, they did this 20 years ago, and they reduced disproportionate deaths of Bangladeshi women. So good practice does exist. So I do support the CRED report. Why? It said that the Commission for Equality and Human Rights, who commissioned the report, should get more money. Well, why not give them more money to do the jobs that I've just asked them to be done? So there are elements of the report that you do support. And it's no surprise, is it, that a report that I commission tells the government I should get more money, but I support it. So that's my summary.
Thank you very much, Jagtar. Thank you very much. And then we go to Councillor Patrick Keitarik.
Good morning, and it's good to be here and hear from other people who are talking about this subject. It's part of my self-education as somebody who's white British to hear the stories. What we're doing, my role is I'm one of the councillors and I chair the Health Scrutiny Committee, and that covers Leicester, Leicestershire and Rutland. So we do look at some of the impacts. We have been, as the previous speaker said, looking at the differential outcomes for COVID in the city. And we're also doing pieces of work, quite interestingly, with the health services and employer, and Dr. Bello made reference to that. And the interesting thing is that, and to be frank, I'm not going to be, as it were, mansplaining it to you. I'm sure this is a little surprise, but it is there in the figures. Proof and documentary evidence is important. That you find that actually there isn't a glass ceiling in NHS work. A glass ceiling implies that you progress at a steady rate and then you hit a roadblock. Actually, all the statistics we get from the NHS as an employer is black and minority ethnic people entering the NHS as an employer just get hobbled from day one. As I said, the glass ceiling implies you progress and then you stop. What happens is the failure to progress amongst black and minority ethnic employees of the NHS, it comes in at day one and you start to slow down, and then the gap delays. And then you see when you get to senior management, you know, what's commonly referred to as the snowy white peaks, where people don't come through. So it's quite a good indicator of what needs to happen in order to change things, which is that day one action. Outside of my work on the council, I work for HMRC, and they've done quite an interesting piece of work that people may have come across in your own organisations, and doing race equality workshops. And it's flipping it around. It's not going into a chief exec's board meeting and giving a presentation. It's actually about smallish groups. We prefer them to be smaller. The two of us as facilitators, there's 18 people. The people who do it are actually volunteers who've got their own reasons. They all work for HMRC, but they've got all their own reasons for facilitating. So it's not a full-time facilitator. These are people at HMRC. And the whole point is there are some things that only the senior management of an organisation can do, but it almost at times absolves the responsibility of us as individuals in an organisation to act. And the reality is it's quite interesting when you have these conversations, because some of them are quite difficult, because you do get the chance to challenge people in that small group work, not aggressively, but people come out with attitudes, as Jagtar said, and you actually get the chance in a smaller group work to address that. But we are doing a study into the health services and employer, and it is interesting. I think it is a false debate about, do you use the phrase BAME? Do you break down into other ethnicities? The NHS, has, amongst its employment, can break it right down. And sometimes you'll agglomerate, and sometimes you'll split down. It's just like any information tool. You use it when it's appropriate, and to kind of make it as if it's an either-or situation, where you either use it all the time or you don't use it at all. It's a false debate. Other issues that we're looking into, and again, these are not particular. Unfortunately, these aren't Leicester specific. We are looking at the adverse outcomes for Black women giving birth. Leicester's no better than anywhere else, unfortunately. But it is quite interesting that you push management for this, and it just doesn't register. It doesn't register that actually this is quite a crucial issue, and trying to get information around that. You really do struggle with the NHS to get the information out. We will be looking in future at the reorganisation of mental health services. Leicester had a very poor record, Leicester Partnership Trust. There's new management taken over. They are making progress, but a lot of this is about a lot of it is about trying to look at some of the problems, and probably the key one, and it's been referred to before now, that for Black people, the entryway into the mental health system is hugely disproportionately via police interaction. So that's when far too many Black people come into the mental health system. It's at a time that they've been, as it were, arrested or are under threat of arrest. So there's a lot to do. And there's a lot of education, but certainly if we're talking in the context of the Sewell Report, you don't need to have personal experience. Personal experience is good, and certainly when I do the work in HMRC, when somebody does decide to talk about it, and I'm fully aware that the pressure to talk about your experiences can be very, very tiring. It comes through, and it's absolutely an amazing thing to change people's attitudes, certainly at that grassroots level. But still, it's a case of even if you had never met somebody from a Black minority ethnic background, if you've been living in the Arctic Circle for the last 10 years, you look at statistics, you look at the adverse COVID outcomes, you look at the adverse outcomes in health service employment, you look at the outcomes for Black women in maternity, you look at those outcomes, and the simple fact is the statistics, the numbers do not lie. I'm very interested because going over with scrutiny, first of all, you look at it, you establish the base, and nothing I've said today, I'm sure, will come as a particular shock to any of fellow speakers or indeed participants. But what I'm quite interested in hearing about is what are the solutions, what works, what's the good practice, be that a grassroots upwards initiatives, or be it, you know, going into the boardroom and knocking on some doors. I'd be very interested to see that innovative practice, because as a Leicester City Council, but also as the health service, you find that ultimately they're incredibly insular organisations. They really don't like picking up best practice. So anything that colleagues can share with us, and in the fullness of time, hopefully we can share with colleagues, would be really appreciated. Thank you.
Thank you very much, Patrick. And I think for the discussion, the conversation part, let's start this way. Do any of you want to respond to anything that others have said? Yes.
Thank you, Ambrose. So I wanted to, I think this is great. I think what Jagtar said is what I hope Leicester will take absolute account of, which is that we don't need any more reports, you know. And I think, you know, these are very senior people who've experienced, perhaps they haven't given their own story, but will have experienced racism themselves over time, but have a broader view of how things have been in society as well as the NHS. And what I would plead to Leicester City Council would be, take it as a given that the Sewell Report got one thing wrong, that there is institutional and structural racism, but then let's look at the 24 recommendations in the context of that. And you will come out with something for our kids, or Leicester kids, that will be far, you know, into the future for them, because it talks about children, very good things about education, good things about stop and search, criminal and justice system. You will then take your public along with you. If you take the first thing that the report talks about is building trust. Well, trust was lost as soon as that report came out, because the very notion that institutional racism does not exist. So I would plead with Councillor Keitarik, who's obviously a man of influence, to take it in that context forward.
So let me just build on that. The trust one is an easy one for me to deal with. There's a Dutch saying that says, trust arrives on foot, departs on horseback. That horse is gone. The trust between our BAME communities and government, it will take a long time to build. Trust and change happen at the same pace. You build trust, change will happen. The other evidence I gave was no more reports. Look at the reports that already exist for guidance of what you need to do. The final one was my deep disappointment about equality impact assessments. I'm quite happy to take offline of what good looks like. I have seen good equality impact assessments that have made a difference, but I see traditionally it's a tick box. That's why they were discredited. We need to drive the change by understanding our policies, procedures, and practices where they have a negative impact. So let's move this agenda on to outcomes. What are the outcomes that that Leicester want to improve? Well, you've got a powerful alliance. You are, as Leicester County Council, an anchor institution. You can influence a lot of the inequalities yourselves by the way you procure services, by the way you hire and fire individuals, the way you promote people. But also you can use the power of the council to influence the ICSs in your area. The ICSs are struggling to set their agenda, set their targets, set their outcomes. Get inside that room and kick some ass. I'll finish on that.
Linda, do you want to respond to anything that the speakers have said?
No.
I think it's an interesting one that Jagtar says about equality impact assessments. I remember picking up a council report once about a decision, and the report was it wasn't a very good report. It was hard, and it said under equality impact assessments, it had nothing built in, and it said a quality impact assessment to be completed after the decision has been taken. That's genuine. I genuinely found that once. I asked the councillor in charge of that report what they thought about that at the full council meeting, and I watched the blood drain out of her face very rapidly. I mean, that's awful, but I think it gives a demonstration to. And again, Jagtar, if you can share good quality impact assessment.
Patrick, the other one they do is they'll do a form and they'll say no impact, no impact, no impact, no impact.
Yeah.
And you go, well, how did the past policy impact? Let's have a look at the outcomes of that policy's application of the last 2, 3. No policy is a brand new policy. Every policy is a rehash of something else. So we can show evidence of how they've impacted. Yeah. So Patrick, I'm sure colleagues will share my email address with you. I'm happy to talk to you offline about how to make that work.
But if we say no more reports, doesn't a report suggest that an effort is being made to look at issues? And if we say no more reports, are we not also saying we stop looking at things and we stop talking about them? This is to all of you.
That's a good comeback to me. When I did the health inequalities report for NHS Assembly, we were going to say more reports on this, this, and this. But when we actually looked at the King's Fund, we looked at the Marmot report, looked at loads of other reports, all the evidence is already there. You don't need any more evidence. Get the evidence and ask why the recommendations have not been applied. I'm not saying don't do any more reports. You could do a report on the reports. You could do a report on the recommendations. Just like any audit committee of a big organization, they do audits. Then they have an action plan against the audit. You know what I've learned through the public sector about audit committees? They are very, very powerful. They have to tick every single action against the audit plan before that report gets filed. What we've done is produce report after report, recommendation after recommendation, and filed them. We haven't actioned them.
I think the question about the reports is and I think the frustration that I can certainly understand is the reports say the same thing, have been saying the same thing for years. I think the frustration about reports is it's kind of a virtue signaling of, well, we're reporting, we're analysing the situation. Well, to be frank, you don't need to. The information there is very readily available. It does not take somebody to work for 6 months on doing an analysis of the information. It's there, and it hasn't, unfortunately, hasn't really changed since we started doing the reports. And reports are a bit like doing the washing up when your house is on fire. Yeah, it's useful, but is it actually going to change the situation? Yeah, and I think what's interesting is rather than wallow in the reports, it is about the action and it is about showing the best practice. The data matters. It does matter because if you're going to measure progress, you've got to have that baseline. Yeah, people will say, "Oh, why do we measure things all the time?" Well, you measure things because you try something and you've got to ask yourself, did it work? And a lot of the time in this world and in lots of other worlds, you do the stuff that you intuitively think will work. It's good stuff, but then at the end of it, unfortunately, it didn't make any difference. So data and reports, it's there, it's useful, but I'm far more interested in a kind of an experimental approach where we try different initiatives and we accept that some of them will work and some of them won't. And I think what happens a lot of the time in organisations is people do initiatives, they don't work, and then the organisation becomes, culturally cynical. Oh, we tried that, it didn't work. Well, we'll try something else. And that's probably a better use of our energies than compiling another report.
And then this, oh, sorry, carry on, Jess.
Yes, I just wanted to say, Ambrose, this is a very good point that you made. But there are 15 very major reports that have been commissioned at considerable amount of money that comes out of the public purse. All we need to do is A, take a look at all the recommendations that have been made. B, is hold communities, trusts and other organizations to account. These equality impact assessments are pointless if there isn't going to be some kind of accountability for them. That is what is lacked. You have never seen, I've never seen in the NHS, a trust being sanctioned for bullying and harassment statistics. You know, poor treatment of staff on a corporate level. Individual level, yes, people will blame individual people. And that is why it is, unless something new comes around, we don't need another report, is what I would say.
Thank you very much. So this is going to be my final question before we open it up to the Q&A. One of the things that I like about the panel that we've got is that we've got JS, who's got experience, national experience, but is also Manchester based. We've got Linda Bello, who is I was going to call it Chester, but is it Colchester in London? We've got Jagtar, who's got experience from Coventry. So my question to you is, looking at those localities, what are you doing? What are your localities doing that can potentially influence change outcomes, health outcomes for racialized minorities?
Well, if I could start. Oh, sorry.
Yeah, start, Linda, please do.
If I could start. I work in a surgery in London and also a surgery in Colchester. The one in London, we have a group of very motivated sort of GPs for many ethnic minorities. So we took it upon ourselves to really try and reach out, especially during the pandemic, to those of our patients from ethnic minorities that were engaging with us, especially trying to reach the patients that had mental health issues. Some of them obviously preferred to be seen in person, but we weren't offering that. Again, these were things that we've all done in our own time. So no one has, the CCG or no one's given us any extra time to do that. I think we're all so busy, we didn't actually apply for that, but we've kind of done it because we know that it's important. In Colchester, where I am, I'd say that there's not as many sort of ethnic minorities. And when I joined the surgery, which was recently, we were already in the sort of grasp of the pandemic. So I haven't really done anything at this surgery. But as I mentioned before, as chairperson of Camdoc UK, we've been doing these webinars where we're kind of educating the community, telling them about the vaccines, giving them our emails, just like as you've seen us offering to kind of speak to them, help them. Other organizations are doing that. We've also got a consortium of leaders from, obviously, JS is in that group, BAPIO, Camdoc, lots of Beta Health for Africa, lots of ethnic minority organizations are trying to make things happen, trying to speak to, we've written letters to Downing Street. We even had a Zoom call recently with Chris Whitty. So lots of, we're trying to do these, we're trying to change the narrative, because it looks like, when they say no more reports, I agree. Because, what we need now is action. We don't need anything written anymore. We need, and it demoralizes the people that have written it as well, I would expect, because most of those trying to write it want to try and help. And I think right now it's just time for action. We're willing, we're ready. Most of my colleagues that can help are always trying to help. As I said, we're all giving our time, not paid, to just help. So I think if the government and powers that be can see the sheer sort of force of goodwill that is in our communities, we want to help. And actually, if we're helped to kind of to kind of level out these inequalities, it saves the NHS money, actually. So this is a win-win for all of us. And I'm really passionate about this, and I think there's loads of us like me that are passionate and willing to sort of engage. So we're here, just get the right people in those boardrooms, and doing these reports and actioning them is what I would say.
Jess, you're going to say something?
Yes, so I think Linda's stolen my thunder. I think there's a lot of stuff that has been happening in the healthcare space, and Jagtar set up another group called APNA NHS, which is hugely influential as well. I think he might want to talk about that. So in Greater Manchester, Andy Burnham set up a race equality panel. And the race equality panel, which is, fairly new thing. So, the point of that is it advises the mayor of Greater Manchester about the challenges and opportunities faced by people linked to their race or ethnicity. And it holds to account, political leaders for tackling the systemic and institutional prejudice that causes inequality. So that is the key thing. You not only get out there and about and look at challenges, look at the opportunities, but also political leaders and other health leaders who so far haven't been able to grapple this. I think we need to look at that more closely about their role in this. And so I would say to Leicester, maybe they need to look at what Andy's done over here, which is making an impact.
So to follow up on JS, what have I done? So there's a personal, what do I do as Jagtar Singh, and what I do as chair. Let me do the chair bit there. What do I do as chair? We have got proper accountability and governance structure in my board. We have a board that is diverse with talented individuals. Forget this lazy nonsense in London. They can't find inspiring BAME leaders who've worked at board level. I've got them. They're easy. I've just tweeted yesterday, we've just appointed a black chief nurse. They're out there, and everybody's now tweeting how wonderful she is. Well, she's been around for a long time. Nobody else bothers to give her a job in the same way. Anyway, so it's an appointment of leaders, development plan for our band 8s and above, running our own course rather than waiting for NHS leadership academies to run them, because they only run a few. There's not enough places on those. So that's the development side. The workforce side, looking at innovative ways of workforce, working with the universities, looking at local talent, acting like an anchor institution. Racism faced by our staff from patients, creating a clear framework of zero tolerance, looking at the disproportionate impact on our staff of disciplines, appointing three people that focus on disciplines, reduced by over 60%, saved us £200,000. Looking at the inequalities of access of BAME communities into mental health. That's more in working in partnership with the GPs, working in partnership with the local councils, actually being inside the ICS, constantly being annoyed and angry that the ICS doesn't take health inequality seriously, not setting clear targets, but being in the room rather than walking away. So that's Jay's associate. That's my trust. And also working with the Midlands Leadership Academy, running events like this that educate, inform senior leaders. As Jay's associates, what I've been doing is going into reasonably large organizations and carrying out an audit for them, having conversations with leaders, middle managers, staff networks, empowering the staff networks, helping them to do their equality impact assessments, not the lazy way. The lazy way is to do a one-day course and say, get on with it. That doesn't work. There's a thing called knowledge decay. I could educate J.S. Bamrah today on equality impact assessments. If he doesn't use it for 6 months, not his fault, he'll forget. But if I educate you today what they are, come back in 3 months' time, and you show me what you've learned in the 3 months in checking, testing, equality impact assessments, I then give you some more knowledge, then you go away, come back in another 3 months' time, and we now ask you to do one. It's embedded. You learn and you carry on using the tools. But we keep sharing the good practice. We keep sharing the barriers for equality impact assessments. Having a clear strategy. I'm working with a few organizations, helping them set their equality diversity strategy. The staff networks and co-production is key. Leicester, please use your staff networks. Leicester, please use your communities to engage with you, tell you what the issues are and how you can overcome them. So that would be my quick and easy advice. That what am I doing as chair? And then how do I then go out and help other people with the knowledge and knowledge that's been given to me by you, with your taxpayer, through my 30-odd years in the fire service?
Thank you very much. Before we go on, before we open it up to the Q&A, I just want to go back to something that Jay said, where he suggested that what we actually ought to do is to foreground institutional and structural racism and then look at the recommendations in the Sewell Report. What maybe we talk about those recommendations, especially around health. Are there any of recommendations there that should be implemented?
Well, I would say, look, there are 24 recommendations. The whole report is 258 pages. And I would do it in justice to say that, you know, you have to apply that science locally, or that wisdom locally. And there are some really good recommendations. What I would say is that in order to do this justice, there has to be a focus group. This report has been, as one of your panel members have said, this report has been out since March. Nothing much has happened really in many cities. Let Leicester City be the trailblazer, you know. Grab it by the horns, check out what doesn't apply locally, take the things that it says about health disparities, as well as you know, about education. It talks about education, talks about criminal justice system. It talks about empowering pupils to make choices about their future potential and support for families. It talks about, you know, inclusivity in curricula. There are things there that you have better knowledge of, you know, and Leicester City Council needs to start by having, and I think, you know, you have somebody external, somebody within, obviously your council. Now, I don't want to tell you how to run this, but as past medical director, I know what works in trust, NHS trust, and then bring somebody from outside, somebody like Jagtar or somebody like that, who can bring in a facilitator who brings in that outside thinking and helps you to bring about that change. That's what I would say. Look at each of those 24 recommendations, the 4 different paragraphs that there are around these.
Does anyone want to add anything before we open it up to the panel, to the audience? Okay, we go to a Q&A. I will look at some of the questions that we've got, and one of them was around the slides. Those are going to be shared, and then let's see what else we've got. There's also a question about, is there evidence of any discernible changes having from health organizations? There's agreement that there's need for accountability and scrutiny on recommendations. Is there anyone in the audience who would like to ask a question? Are there any questions? Anyone? So if they are...
Let me ask a question to you.
Yeah.
How are you going to take this conversation forward?
Well,
what happens next?
Okay, so what we are going to do as Civic Leicester is that this conversation, we will make it publicly accessible. We will make sure that a wider audience can access it. And also, Civic Leicester over the years engages with the City Council, and that engagement will continue. Some of the engagement includes, inviting the council to appear on panels such as this, asking questions about things that are not working, making suggestions on how we improve. This is what Civic Leicester does. So that work is going to continue. So since there are no questions from those attending, I'll ask if you could maybe do a summation and then we close.
Should we go in reverse order, Ambrose,
Okay.
this time?
Okay. So we start with Jagtar and then Linda and finish with JS.
I'll just finish with the Mahatma Gandhi quote. We are the change we've been waiting for. Nobody else is going to do anything for us. If you want change to happen, get involved and get it done. Challenge with respect, but challenge and be a critical friend for people who will support you in achieving your objectives. Be clear about what you're asking for.
Thank you.
I'd just like to conclude by saying I agree with JS and Jagtar that the fact that this report really downplayed the impact of racism on the society. The Race and Health Observatory was set up in May 2020, and it consists of global experts in health inequalities, and this was specifically a challenge to tackle the specific health challenges facing people from BAME backgrounds. So they've already clearly stated that this racism exists, including within the NHS. So the reports are already there, as we've said. There's already evidence. We don't need to be setting up any other bodies. We already have a body for that. The existence of RES also supports the fact that we know that it's an issue, and all our other sort of public health factor of public health, or all the royal colleges have also affirmed all of this. So when a report has come out which appears to downplay or ignore existing evidence, then of course it means that the community are going to be a bit upset, and obviously the trust is going to be fractured. So really we should be looking at, apart from implementing some of the good points in the report, also looking at how we can build back that trust. Jagtar was saying how trust comes on foot and departs on horseback. It's going to take a long time, and we really need to get those seeds sown. If we're going to achieve any of this, we really need to be building on this. And I will say again, there's lots of us that are willing and able to help with this. We just need to be at the table. We just need all these subcommittees that need to be formed. We need to be in them. We need to be there, because we need to look at what didn't work out in the past. Change those, because we need to build a better future for our children. Britain is becoming more and more multicultural. These ethnic minorities are going to be making up a lot more of the population. It's for the good of all of us. So there was a very good comment in the thing that all of us, it's not just us being that are meant to be trying to make sure that we're okay, that our health comes are better. It's everyone, all of us. It's not only me in the surgery as a Black doctor in my surgery that is meant to be caring more about my Black patients or my Indian patients, my Pakistani patients. All of us should realize that these are a group that need a bit more care, that that are suffering, where it is unequal. We do that for patients that have other conditions. We need to realize that this subset of patients are suffering. We need to, when my Black patient is pregnant and has to go to the hospital and she's worried, I need to give her the time. I shouldn't fob her off. I need to take 10 extra minutes and talk to her. It shouldn't just be me that realizes that. It should be all of my colleagues. So more and more education, the government, all the powers that be. I always think I'm just a lowly GP, but I'm happy to be involved in anything that needs to be done, and I have lots of other people like myself that are happy to help. So please use us, and we're always here. And that's all I can say. We're so passionate about this. It's our brothers, our sisters, our colleagues that are dying. We want to really make sure that we can improve things.
Thank you, Linda.
Right. Thank you, Ambrose. Thank you, Linda and Jagtar. Really not much to add, except, you know, I think that there are so many imperatives here, you know, to get this right. Because if we're a socialist society, which I'd argue we're not at the moment, then it's the right thing to do. It's the right moral thing to do, you know, about equal rights for everybody. If we were a capitalist society, then it makes sense for all your ethnic population, all your ethnic minorities, to also be strong in terms of helping the economy, particularly at a time when we're going to be facing a real downturn in our financial outcome. So for many reasons, there are really good imperatives why we need to get this right. And Leicester is in a very good place, being the most diverse community that there is in the whole of the UK, to set the tone right, which other people will emulate. And as ICSs are being formed, then what you do there will be looked at by others to say, well, that is a good model to work towards. The final thing I would say is that I hope that your community will work, that communities will work together on this. I really hope, I mean this in a nice way, Ambrose, don't take it in the wrong way, but I think somebody needs to hold Leicester City councillors to account. Today we met with Patrick, who seems to be amazingly well informed and really bold. I don't know what the other councillors are like. Obviously I knew Keith Vaz very well, still do, and he did a lot for the community there. I don't know other people there, but I think there has to be that accountability. Why aren't things moving in the pace and direction that they should? Accountability is key. Now, one thing I would say that I've learned a bit later on, I've been in the NHS 40 years in October this year. I was born and brought up in Tanzania, did my medicine in India, went back to Africa, came here. So I've got a quite wide view of things. I think it wasn't how clever I was, which I'm not. There are people, doctors and psychiatrists, much more clever than I am. It's all about relationships. It's all about trust. It's all about respect. And I think if we do all of those things, it doesn't matter how clever we are. We can actually have a very harmonious society. Thank you.
Thank you. Thank you. Thank you. Thank you very much. So, so again, I will end with thanking you, JS Bamrah, Linda Bello, Jagtar Singh, and also Councillor Patrick Keitarik for taking the time to attend and speak to us today. And also many thanks to those who have attended. I hope you got something that you can take away with you that will also inform your own practice and engagement as a citizen or a resident, or as a person who lives in communities. And I will also finish by reiterating that it is very important that when reports such as Sewell Report come out, we look at them and we look at what they are saying. We also look at our own experiences. We see if those reports speak to our experiences. If they don't, we speak up. There's a saying which says that, I'm going to say it this way. There's an old African saying which says that to be silent is not to speak, which means that if you are silent, you are silent. If you don't turn up, you are not there. So when issues like this come up, let's look at them, let's respond, let's engage, let's speak up, let's ask for the change that we need. And also let's tell others around us what is happening, because if we don't, nothing will change. The system and structures that we've got do not work for people from Black and ethnic minority backgrounds, and they will continue not to work unless and until we insist on the change that we need. So follow us on Facebook and Twitter, social media. I will also be sending out PowerPoint slides and links to relevant documents in follow-up emails. So once more, thank you very much to our speakers, and also thank you for attending. Thank you.